Hey everyone, it's Adam Farkas. Welcome to another ODwire webinar. Thanks for coming out tonight. And tonight's show is all about OCT angiography. And, we did a show, I guess, just a couple of weeks ago about OCT, sort of the first one in this series, and it was incredibly well attended and people really enjoyed it. And I was even looking more forward to this one because OCT angiography to me seems almost like magic. I know that, from the time I was a student way back when, angiography was always a very sort of invasive procedure, difficult, patients hated it, and so forth. It wasn't something you'd want to try to do routinely, but OCTA has really changed that completely. We now have access to a diagnostic test that was really quite limited before, but now you can basically use universally. So it's an incredible technology, and I'm really happy tonight to participate in this webinar because it's all about OCTA and specifically in the context of diabetes. So I guess strap in and enjoy tonight. We have Dr. Julie Rodman with us. And if you weren't at Julie's first talk, you missed something, you should definitely go back to ODwire and watch it again because it was fantastic. So I think just about everyone here knows Julie from her work at CEwire if you've taken that course. But Julie's the Chief of Staff at the Broward Eye Care Institute in Fort Lauderdale, Florida. And she's actually published over 30 publications with an emphasis on retinal disease and a lot on OCT. And in fact, she published a book, an OCT Atlas, which is a book of case studies. And as I believe it was the first one ever written by an OD. So I couldn't think of a better person to actually walk us through tonight how OCTA works. So with that said, Julie, I think you can take control of the system, and why don't we get it underway?
Thank you, Adam, and thank you all so much for coming tonight. So I'm extremely excited about tonight's webinar in particular because, as Adam said, my biggest passion thus far in my career has been OCT and OCT angiography in particular. We were one of the first adopters of OCT angiography at Nova, and I feel pretty clinically adept at using the technology at this point. So I'm excited to share what I know with you and hope that I can make this technology a little bit more user-friendly and not as frightening to everyone this evening. So as Adam mentioned, tonight we're going to particularly emphasize diabetes. There's a lot to OCT angiography, and we will do a future webinar on more of the outer retinal portion of the eye, but tonight is going to be particularly on diabetes. So let's jump right into it. So what I'd like to kind of start off with is a simple question that I get asked really every time I talk about OCT angiography. And that question is, Dr. Rodman, why in the world do we need OCT angiography? We've been using OCT for X number of years. We've been taking, such good care of our patients. Why do we need this technology? And what I would say is that this is a profession that is changing all the time for the better. So we don't want to stick with the status quo. We want to always improve upon our technology, which in turn will allow us to take better care of our patients. So in the early 2000s, which probably a lot of you on here don't even remember, we used something called time domain OCT. And when this was introduced, I remember it was so huge for everybody because it was really the first time that optometrists or even ophthalmologists were actually able to get a non-invasive visualization of the retinal anatomy. And this provided us with obviously information that was critical to our patient care. The problem with time domain OCT is that, as you can see in the image, there's a lot of questions on what you're what you're seeing. Is this an artifact? Is it a true abnormality? So the company said, well, we got to do something about this. So a couple years later, spectral domain OCT came out. And what you can appreciate there is that the quality of the image is obviously much more dramatic and clear than the time domain OCT. And now most of us are using spectral domain OCT. We get more scans per second, allowing for a higher resolution image. But the thing to remember is that these technologies are really exclusive to structure. So when you're looking at these, it's giving us information about what's happening, again, anatomically, but it's really not giving us information about what's happening at the vascular level. So that was the piece that was missing from these amazing technologies. And so a couple of years later, again, the company said, we got to do something, we got to do better. And so that's when OCTA was introduced. And OCTA essentially is the optometrist or the retinal specialist or the general ophthalmologist way of doing an angiography without doing anything invasive. And so what you're visualizing on the right-hand side of the screen there is what the angiogram essentially is going to look like. And it looks different than the OCT scan because you're visualizing vasculature. Okay, so the frightening part about OCT angiography is obviously looking at this image and saying, I don't know what I'm looking at. And that's fair, right? Because it's a completely different image than what we're accustomed to seeing with an OCT scan. Pardon me, went too fast there. So when someone asks me or someone that's very passionate about OCT angiography, why do I need this technology? I would answer that it allows us to take the best care of our patients. We're going to visualize disease faster and before sometimes it's even visibly clinically. It's going to allow us to keep more patients in our practice because before the advent of this, anytime we suspected something, we had to send it out for fluorescein. So now we're able to do this on our own. And really, I would say for the new generation of optometrists, they like to have the latest and greatest tricks on the street, and this is it. So if you're one of those people that loves new technology, this is the technology that you want to get. So just to emphasize one more time, the pros of OCT is it allows a phenomenal visualization of retinal anatomy, retinal architecture. It's non-invasive and very easy to perform. The problem, once again, is that we cannot visualize vasculature. So when you begin to do OCT angiography, what you're going to appreciate is that you never look at an OCT angiography image or an angiogram alone. You always want to look at the angiogram alongside the B-scan. When someone sends me just this image on top here, it's very difficult for me to tell them what's going on. I need to see it alongside the corresponding B-scan. The reason is, remember that one of them is going to provide us with that structural view, and the other part of it is the other image, the angiogram, is going to tell us what's happening at the vascular level. Regular OCTs are stationary images. What I mean by that is if I were to image myself right now in 10 minutes, in 15 minutes, my OCT scan is going to look identical, essentially, if I'm imaging the same area. But OCT angiography actually images movement. It looks at the movement of red blood cells within the retina. So because there's movement going on, anytime you take an angiogram of a patient, essentially there are going to be differences in the images because there's movement involved. It's the same idea if you were to take a picture of a waterfall. If you were to take one now, 10 minutes and 15 minutes later, those pictures are going to look very different. So these are two very different technologies that really you have to kind of look at together and in sequence to understand. And we'll go into more detail in just a minute with what that means. So on the left-hand side of the screen, you'll see on the top the angiogram, and once again, the corresponding B-scan on the bottom. So here's really the summary of what I've been saying for the last few minutes is that OCT is phenomenal for any elevations or depressions in tissue, things like drusen, things like fluid, any overall elevation or depression. OCTA is going to be better at visualizing either too much blood or not enough blood. So if we're suspecting that a patient may have a choroidal neovascular membrane, we may visualize that structurally, but really to determine if there's actually an active net going on, we really would need OCT angiography. Same with diabetes or vascular occlusive disease. Looking at these conditions and understanding, is the patient getting good perfusion? Regular OCT is not going to tell us that. This technology, OCT angiography, is going to allow us to kind of delve into or in depth into the vascular supply. When you look at OCTA next to fluorescein, there's a couple of things to keep in mind. They are not the same technology, and each of them have their perks and their downsides. So I'm not going to tell you that OCTA is better than FA, and I'm not going to tell you that FA is better than OCTA. Honestly, each of them have a purpose, and there are still very many times when I do need to send patients out for an FA, and these are some of the reasons here. So fluorescein angiography will allow for a very wide field image. One of the limitations of OCTA, which we're working on, is getting a larger field of view. So OCTA gives us a beautiful image of the posterior pole, but doesn't do such a good job at imaging mid-periphery and periphery. Now, there are technologies that are out there, and there are more being created that are going to allow us a wide field view, or let's say of the mid-periphery. And that's actually super important because some of these vascular diseases actually affect the mid-peripheral retina in a negative way. The other thing too we know is that fluorescein requires a dye where OCTA doesn't, so that's obviously a perk of OCTA. The OCTA actually provides better resolution than FA, and I'm going to show you that in just a few when we start going through examples. You can see things on OCTA that you can't see on fluorescein because you do not get any leakage on OCTA, and we'll talk about that in just a minute. OCTA is very affected by movement because remember I told you that this technology is based on the movement of red blood cells within the eye. So if any time the patient moves, the machine might think that that's actually a red blood cell moving. So movement in a patient that has difficulty sitting still is not the best candidate for OCTA. OCTA allows us for a three-dimensional segmentation that the fluorescein really doesn't. In fact, with the advent of OCTA, we've determined or we've learned more about what we call the deep retinal flow or the deep retinal tissue that we did not know about before in the fluorescein angiography images. So that's actually very interesting. And really what I would kind of summarize on the last thing here is that OCT angiography is very, very fast, whereas FA takes time. Patients have side effects from the dye. So it's a little bit of, you have to be more careful when you recommend a patient have FA versus OCTA. I mean, you can do OCTA 10 times in a row and there's really no negative effect except maybe for a dry eye on the patient. So how does this technology work? So essentially you sit the patient down same way behind the machine and you're going to capture two sequential OCTA B-scan images, which is what you see on the left-hand side here. So you're going to click once, you're going to click twice. These two images are what we call our parent images. From these images, there's about 10 or 11 sister images that are created. The machine takes those sister images and looks for any differences in signal or in reflectivity between those images. If you think about it, the only thing that should differ is something that's moving, okay? And we're not going to see that on the OCT scan. However, the machine has an algorithm or a way of assessing and looking for those differences. So we take those images and then we get what's this middle picture called the OCTA B-scan with flow overlay. Anywhere that you see red on that flow overlay image is an area where the algorithm or the machine said, you know what, there was a difference in the reflectivity between my different scans. So because, once again, because anytime there's a difference, it's going to be thought to be motion, those are going to be areas where there is suspected blood. Now, it makes sense that you would have red dots up in the inner retina because this is where our vascular source, our capillary network lies. It would also make sense that you would have heavy red down in the choroid because we know that the choroid is made up of all blood. With OCT angiography, the interpretation piece comes in looking at areas where you shouldn't have any blood. For example, the retinal pigment epithelium. That is an avascular tissue. So looking at the RPE and noticing little red pieces like this in the RPE, you have to start asking yourself, is that artifact or is there actually an abnormality on the OCT B scan? So this image is quite important and actually a very integral part when you're learning to interpret OCT angiography. From this B scan, the machine then takes what we call en-face or coronal cuts through the B scan. Those coronal cuts create angiograms that are going to correlate with different levels of the retina. So this angiogram, which you can see on the bottom here, this white line is pretty high up. That means we're probably cutting through somewhere up in the inner retina. As you go further down, this line is going to move further down, and this angiogram is going to look different in appearance. I'm going to show you what I mean right now. So if you look at this kind of schematic of the retina, these are the different layers. We have the inner retina on top, we have our retinal pigment epithelium, we have our choriocapillaris. So when you start to take en-face cuts in the same manner, like this, coronally across the retinal anatomy, you're going to create different looking angiograms. So here's an example of what I'm talking about. If you look on the left, you'll see the top angiogram is called the superficial plexus. That superficial plexus is the blood supply feeding the most superficial part of the retina. So what you're noticing here are capillaries. This is the fovea avascular zone. That is why it's black. So on angiography, anywhere that you see black is an indication that there's no perfusion there, okay, or no blood supply, I should say. So this appearance is what the superficial capillary bed looks like. And what this is telling us is that's essentially, give or take some microns, the inner limiting membrane to, let's say, the inner plexiform layer. As you move more posterior through the retina, this next area is fed by what we call the deep capillary plexus. The deep plexus looks a little bit different. You can see that the capillaries look more truncated, they're shorter, they're more stout. And we still have the foveal avascular zone here. So this is the layer that fluorescent angiography actually does not pick up upon. So this is extremely, we've learned so much about disease processes that originate in the deep plexus, for example, macular telangiectasia, because fluorescein doesn't allow us very good visualization of that plexus. As you continue to move more posterior, you're going to hit the retinal pigment epithelium and the area surrounding it. That area, as I mentioned before, is an avascular area, so that is why this slab is completely black. Remember, black means no flow, no blood vessels. When you see a white area within the avascular slab, you need to ask yourself once again, is that an artifact or is that actually an anomalous area? And then the most posterior area is going to be the choriocapillaris. And the choriocapillaris slab should be white like this, like a sponge, because remember that the choriocapillaris is a blood-filled tissue. So understanding and remembering or recognizing these four slabs, or depending on the technology, might be give or take a couple of slabs, but understanding what these slabs look like is really essential in understanding OCT angiography. So when you sit the patient down behind the machine, you're going to have choices, right? You're going to decide, what do I want to image? When you're imaging the retina, we have three choices. We have a 3x3 scan, a 6x6, or an 8x8. What that essentially means is that a 3x3 is 3 millimeters horizontal, 3 millimeters vertical. 6x6 again is the same, 8x8 is bigger. So the automatic question you're probably wondering is, well, why wouldn't I just do an 8x8 on every patient? And the simple answer is that the bigger the scan, the less resolution. So a 3x3 scan is going to give us much better resolution than a 6x6 scan. So and then an 8x8. So what I like to do is I like to start off usually with a 6x6, which is a really nice kind of middle of the road scan. And if there's something that I need to see in more detail, then I will run a 3x3. An example of that is on the right-hand side of the screen. This scan over here is a 6x6. You can see the foveal avascular zone right here. And what I'm noticing is that, and I'm going to talk about this in just a little bit, is there are some anomalous vessels around the FAZ or foveal avascular zone. So what I then do is I do a 3x3, which will blow up this foveal avascular zone in a lot of detail, allowing me to visualize these anomalous vessels in a much more distinct way. When you're doing the disc, we have the same idea, 3x3, 4.5 by 4.5, or 6x6. And really, this just summarizes what I just said. The smaller scan sizes are going to give you a lot more detail, but a smaller field of view. Something that OptiView, or now Visionics, has in their technology is the availability of this montage image. The montage image will allow you to merge together the optic nerve head and the macula. So you can see that here. You'll scan the optic nerve, you'll scan the macula, and automatically the machine will merge those images together, allowing for about a 10x6 millimeter image. This is kind of the way that we get around that limited field of view that I talked about before. So there are some solutions to kind of getting a little bit further out than just doing a scan all by itself, meaning a retina scan or an optic nerve head scan. Okay, so the fun part of this is what we're going to do now. This is taking this information and applying it to the clinical setting, which is really what we all care about. So when we're talking about OCT angiography, it's very important to understand what layer of the retina the disease affects. So for purposes of today's conversation, we're doing diabetes. So diabetes is a disease that affects the neurosensory retina. The neurosensory retina is essentially the area kind of above the RPE, above the ELM. So we're looking really up here at this area. If you recall from my slide before on anatomy, the angiograms that correlate with the inner retina are going to be the superficial plexus on the left and the deep plexus on the right. You can again notice on the bottom, the white line is pretty high up, indicating how high up we are in the retina. And the purple one is kind of in the middle, indicating we're moving a little bit further down into the retina. So for the purposes of diabetes, the slabs of interest are going to be the superficial and deep capillary plexi. There is literature now, and we'll talk about it in just a minute, on some of the other slabs, but for purposes, really for the most cases, these are going to be the slabs that you want to focus on. So on the top of this slide, I have what I call the control. I always tell my students that if you don't know what normal looks like, you're never going to appreciate abnormal. So I put that up there so that you'll be able to compare the diabetic eye versus the control eye. So some common findings, and there are more, in diabetes include, number one, just retinal capillary non-perfusion. So I told you before that retinal capillary non-perfusion is going to be black. So if you see areas, and I put the red arrows there, if you see areas that are black, those are areas that are not getting enough vascular supply. So if you look up at the control, you'll notice that around the foveolae vascular zone, you're not going to see those big black pouches. The second thing are microaneurysms, which are capillary outpouchings. So something to keep in mind is that a microaneurysm is, again, the blood is still within the blood vessel. It is an outpouching of the blood vessel. Think about a hemorrhage. In a hemorrhage, the blood has left the blood vessel. Remember that OCT angiography can only image blood within the blood vessel. Remember, red blood cells within the blood vessel. So microaneurysms will image most of the time on OCT angiography, but hemorrhages will not, because hemorrhages are leaking out of the blood vessel. So one of the reasons that we get such beautiful visualization on OCT angiography is we don't have the noise from the leakage. So those little white spots that I circled with the red circle there are little microaneurysms. The other thing you might see is general enlargement of the foveolae vascular zone. So you can see that more black means less perfusion, results in larger size of the FAZ. So let's look at an example. This is a 45-year-old African-American female who comes in so proud of herself. She says, Dr. Rodman, my blood sugar is excellent. I don't know the number, but my A1C is 7, and I'm really, really proud of myself. And you guys probably remember that the A1C that we want is 4 to 6. So she's a little bit elevated, but in my clinical setting, an A1C of 7 is actually pretty good. So I'm okay. I'm like, okay, this is going to be a fabulous exam. I take a look at her retina. You can see the picture here, and pretty unimpressive, right? It looks good. She may have, one little microaneurysm there. And her OCTB scan looks uneventful except for some vitreomacular adhesion. So at this point, before the advent of OCTA, I would have told my patient that you're right, you are doing amazingly well. I'm going to send a note to your primary care physician, letting them know how well you're doing. But you know what's coming, because this lecture is on OCT angiography and taking the best care of your patient. So we do OCT angiography on our patient, and this is what we see. And you'll recall from what I just told you before that some of the warning signs of positive diabetes would be things like large pockets of capillary non-perfusion, microaneurysm formation, and general enlargement of the FAZ. And so the question that always comes up, at this point, whenever I give this lecture is, okay, so what? What would you do differently? Well, I think the answer here is really the education piece, because 2 minutes ago I just said I would have told this patient to continue to do what she was doing, whether that means going home and eating a brownie or, excuse me, sitting on the couch and watching TV with the remote in her hand. But now, with this information, my education to this young lady is going to be very different, right? We need to take a different approach because we see these early changes that we did not see from the structural standpoint. So understanding also that the primary care physician may have thought that whatever this patient was on, it was adequate, when really it's not adequate. So to me, that is the most important part. If my doctor tells me to keep doing what I'm doing, I'm going to keep doing it. Whereas if I were to know that what I was doing was not working and that bad things were on the horizon for me, I would change my behavior. Here's a proposition. The top is what I just showed you. What if a year later, this is what happened? Okay, so this is just something to think about. Changes build upon each other. If changes are not made, good changes, and if good changes are not made, the problems are going to get worse. And you'll notice on the bottom picture there that is just a mess, right? We can't even really visualize in the deep capillary plexus here. You can't even visualize the border of the FAZ because there is so much capillary non-perfusion. And so this is an example of something that could happen potentially to a patient that we don't kind of make changes to at that early stage. This is a 45-year-old glaucoma suspect. You can see the optic nerve obviously is quite glaucomatous. Diabetic for 5 years. And he candidly reports to me that, Dr. Rodman, my blood sugar is not the best. Every medication that my doctor puts me on, I've had trouble with, and I'm sure that this sounds very familiar to all of you. These are really real problems that these patients have, and he's trying, but he's not doing the best job, and he recognizes it. And, you look at his picture here, and it's not really that impressive. He's got some vascular changes. He probably has high blood pressure as well. But don't see anything blatantly obvious, at least from the diabetic standpoint. So here's that picture again. And there's what's going on his OCTA. And guess what? He's got a lot of problems. Okay, so he's got this, again, pardon me, really generalized enlargement of the FAZ. He's got anomalous vasculature here that is kind of going into the FAZ. So just a lot of capillary looping, we call it. So not really the best image in a patient that really did not look that impressive without OCT angiography. And there I blew up the macular area just to show you that from the clinical standpoint, there's really nothing there. Okay, so this is something that we all would be very easy, and all of us would miss it, without getting this angiogram. This, once again, would be a patient that you would say, you know what, don't worry about it. Even though you're having trouble with your medication, your eyes look phenomenal. And guess what? They really, really don't. So this would be a beautiful way of explaining to the patient that something needs to be done. This is a really nice picture of what I was telling you before, how OCTA gives you much better resolution than fluorescein angiography. So on the left is the fluorescein, on the right is the OCTA. And I always like to kind of point to this little area here, this anomalous vessel, and how it almost kind of just blends into the background, and you can really appreciate it on the OCTA. So this is because, once again, there's no leakage. So these hot spots here are all hemorrhages, which are going to leak on FA, but you're not going to see them on OCTA. So yes, there are definitely downsides to not being able to visualize leakage. But what I would say is that when you're trying to identify anomalous vasculature, not having leakage is definitely a plus. Let me give you another example. These are all going to be examples, which I think are going to be helpful to all of you. So this is a 55-year-old African-American male. He's got no diabetic retinopathy on the fundus exam. I don't have the fundus image here, but there was no retinopathy. But this was the issue. He was 20/50. And the problem is that he's only 55. So the first thing that comes to mind is always, oh, it's got to be lenticular changes. The patient's got to have a cataract. But guess what? No cataract. He's only 55. So, you're thinking to yourself, without OCT angiography, you're looking at him and you're scratching your head. And really, if you didn't have this modality, you're almost forced to send it out because you have to sign off on your chart and you have to explain why the patient is 20/50. We luckily had OCT angiography, so we got it. And you can see here once again this very anomalous FAZ. You can see a huge microaneurysm. You can see tons of capillary non-perfusion. So this technology has given or shed more light on a term called macular ischemia. And what macular ischemia essentially means is clinically, we're not seeing anything, but at that vascular level, there is a high level of ischemia going on, resulting in decreased vision. So really the definition of this term is, from a clinical standpoint, we really don't see anything, but there's a functional deficit. There's a functional deficit that we can't account for. And having the angiography image explains that functional deficit. So I'll emphasize here that without this technology, legally, you would need to explain why this patient's vision was down, and that would be very challenging without this. I'll also lend a little clinical pearl. Macular ischemia is not that easy to treat. So if you saw this and you said, Mr. Jones, I'm going to send you over to retina for an anti-VEGF injection, you're going to do really, really well. That would probably be a misleading line. The reason is that anti-VEGF targets anomalous vasculature. Obviously, it will try to target areas of ischemia as well, but it's not as effective as in a patient that has, let's say, neovascularization. So we want to be careful what we tell patients that have macular ischemia. It's, again, not going to have the same visual prognosis as a patient that has macular edema. This is a patient here that had a history of panretinal photocoagulation, and he reports with reduced vision bilaterally. Once again, the patient doesn't have lenticular changes. And looking at the fundus images, you can certainly see that the patient had extensive PRP. But the maculas actually looked like the best part of the image, right? They're not not the clearest, but you can certainly see that there's no laser scars directly in the macular area. So once again, you ask yourself, in the absence of any optic disc pallor, in the absence of any blatant macular issues, why is the patient's vision reduced? And here you can see the 4 slabs on top that we talked about before. I have the red box focusing on the slabs of interest, and you can appreciate, wow, the really anomalous FAZ, this very anomalous kind of, again, capillary loop here, lots of microaneurysm formation, just a lot of blunted vessels that are just kind of stopping midair, and in the deep plexus as well. So this patient, even though they've been treated and we don't see any, quote, active disease, proliferative or non-proliferative, there's certainly a lot of indication there has been a deep-seated ischemic process in this eye. And this is the other eye, very similar to the right eye, the same thing, just a very anomalous appearance to the fovea, the area surrounding the fovea, lots of capillary looping and telangiectatic anomalous vessels. Here's another patient. This is a 50-year-old diabetic female. She's been diabetic for 10 years. Her A1C is 5.9 and her vision is normal. We know that the longer the patient has had diabetes, the more prone they are to developing retinopathy. And 10 years is a good amount of time. But her A1C is really good. Her vision is good. Okay, so these are, her pictures. And once again, aside from being a glaucoma suspect, which almost all of my patients are glaucoma suspects as well, I wasn't majorly impressed. And I'm going to kind of humble myself for a minute and just give a shout out here to this camera. This is a center view in the DRS Plus. And the reason I'm giving a shout out is because when I looked at this patient, I did not see anything. I'm going to be 100% honest. I looked 90. I thought the patient looked fantastic. And then I took some images. And when I took the images, I was like, oh my goodness, look what I missed. And so let me kind of blow these up to show you. It's much more prominent on the left eye than on the right eye, but hopefully you can appreciate this anomalous vasculature here. And it's funny because when I was in the room, I'm like, yes, this patient looks excellent. And then I took the pictures, and the student and I looked at each other, and we were like, how did we miss that? So phenomenal camera, phenomenal images. Regardless, this patient had this anomalous vasculature, but yet they were 20/20. So you know what's coming next is I did angiography. So this is the superficial plexus. You'll see on the right-hand side of the screen here. This is kind of the view where you can pick any slab and get a larger visualization of that slab. So this is the superficial plexus here, and these are those anomalous vessels. And what essentially you're seeing here are probably some microaneurysms, once again, capillary looping, lots of areas of capillary non-perfusion kind of all over the place, big chunks of capillary non-perfusion. This is that en face cut where you can visualize some of these vessels. But the really cool thing is that the B scan really showed nothing, right? The B scan is showing a completely normal retina. So let's say you saw this patient and you were suspecting, is that neo? Is it Irma? I mean, what could it be? It would be very rare to have a neovascular response just in the macula, but it certainly looked that way. But this is really identifying that these changes look like, again, anomalous vasculature with some microaneurysm formation. And let me just go back here. This is the deep plexus here of the right eye. You can see that these vessels go all the way through to the deep plexus. And here's the left eye, the eye that was much more visible clinically. Once again, a lot of anomalous vessels, a lot of areas of capillary non-perfusion, and the deep plexus. So I will just kind of, the recap of this is that if I didn't have good technology, whether it be the camera, whether it be the OCT angiography, I probably would have dismissed this patient and said, okay, you know, you're doing really well, A1C is great, we'll see you in a year. The problem is that this is going to lead to what I showed you at the beginning of this presentation is 1 year later, what if? You ask yourself, what if? Having this amount of capillary outpouch, remember that microaneurysms are the first sign of damage in the eye. Having this amount of damage is going to lead to progression of changes fairly rapidly. So understanding that this exists and really calling attention to it, and you can see here that it's not proliferative, it was extremely helpful to us. This also highlights, which I'll talk about a little later on as well, the availability of this multi-scan view. So what I did, just because I thought this patient was so interesting, is I had seen her in March of 2022 recently. I asked her if she would come back about a month and a half later. I wanted to see what these vessels were doing. I was really curious. And so this technology allows for outstanding kind of a trend analysis multi-scan view, where it lines up for you the images identically. So you don't have to worry about it. You can look at any slab you want, and the machine will automatically line up the images, and you can look at every single area and see what's going on. And not that I was expecting to see any change, but guess what, guys? Look at this area here. This is only a month and a half later. Look at this large area of capillary non-perfusion. This was only a month and a half before. And remember, this is lined up identically. So it's kind of just a really nice visualization of the changes that are happening at this subclinical level. And this is the left eye, same idea. Multi-scan view, same idea of the visualization from one visit to the next. This here is a 62-year-old Indian male, diabetic for 20 years. So we're expecting there to be retinopathy after 20 years. He says he has high blood sugar levels, and he also reported a recent decline in his vision, greater in the right eye than in the left. And you're probably looking at these and you're like, man, there's a lot of stuff going on. I'm not really sure what to look at first. So what I wanted to do here is I wanted to kind of break down the images with the angiography so you can see how useful this technology is. So here's my right eye. What a mess, right? You look at it and you can see there looks like there is some type of fibrous proliferation here. There looks to be anomalous vasculature here, anomalous vasculature here. There looks to be some more fibrous stuff going on here. You're probably looking at this and you're thinking, okay, you know, hopefully everybody would send this out. Okay, hopefully everybody would look at this slide and say, or this image and say, there's definitely proliferative disease here because of all of this fibrous area of tissue. But I really wanted to break this down just to show you how cool the angiography is in really identifying images of areas of proliferation. So let me actually go back here. Two very succinct areas for me were this area here, and maybe up here there was also some anomalous stuff. So when you look at the angiogram, what you're going to appreciate here, and I always kind of look at the fovea because that helps me to localize where I am, what you're going to notice is this big frond here of anomalous vessels. This is all neovascularization, this whole area. So embedded within this fibrous proliferation is the neovascularization, which would make sense, right? And neovascularization leads to this fibrous proliferation, which eventually can lead to a retinal detachment. And the other area of interest was up here. I said that it looked a little bit anomalous to me, and it certainly is anomalous. Here is the anomalous vasculature. So kind of, neat that you can actually identify very specific areas. And I'm going to show you how you could tell that this is not IRMA, which we'll go into in another case in more detail. But on the OCT-B scan, you can see this area up here living in the vitreoretinal space. Remember that neovascularization, new blood vessel growth, lives in the vitreoretinal space. So the fact that it's living up above the retina is an indication that it's not IRMA, because IRMA is intraretinal. So this is definitely proliferation corresponding with this area over here. The other eye was the quote unquote better looking eye. However, you'll notice that there are also a lot of anomalous areas. You can see over here, there looks to be a lot of anomalous vasculature. And I would say, this area here is the highlight of at least what I'm looking at. There's a lot of exudation in the retina as well. But as far as looking for a proliferative response, this is where my attention would be. So once again, find your fovea, kind of look at where the blood vessels cross. And down here, you can appreciate this neovascular area. You will also appreciate here that what I mentioned before, the field of view is limited. Okay, so that's one of the limitations that we're working on, trying to come up with a way to get farther out. But you can definitely appreciate this neovascular frond. But what's even cooler here is that looking at this image, I wasn't impressed that there was any other area on here that was consistent with proliferative disease. And there definitely was. There's a huge area up here, which is probably embedded somewhere within here that we just can't see. And there's another one over here. So somewhere near the optic disc. So this technology is it's incredible, because not only does it pick up the obvious ones like this, but it also identified areas that were not as obvious to me. And you can see down here as well on this structural B scan, this area over here, which is once again living in that vitreoretinal space, indicative of a neovascular response. And yet another, at fast glance, doesn't look too bad, but does it? Once again, you look at this, and if you're just looking at it quickly, it doesn't look too bad. There's vitreous debris kind of floating around. There might be some microaneurysms down here, but there is a problem, and that red arrow is pointing to this big problem. And you would never guess, this is crazy, but if you move your lines, your segmentation lines up to the vitreoretinal interface, look at this neovascularization. I was so impressed by this. It was just such a phenomenal image. So understanding, God, this is weird. I didn't think patients would get a neovascular response with very limited retinopathy, but this is a very ischemic eye. And maybe this would have been missed without looking at the angiography and understanding how to move the lines and kind of really hone in on this anomalous area. This is a fantastic capability of the AngioView. It allows us to use colors to localize lesions. So what this scale on the side is showing us is that these different colors correlate with the level of the retina that you're at. So if you click on color overlay over here, that will take you to this kind of mapping. And anything that's living in the vitreoretinal interface, meaning neovascularization, is going to be green. And that's what that means, vitreous green. So looking at this image, and I blew it up for you, this whole area down here was this area here. So it shows you that that area is living in the vitreoretinal interface. And you can really see it here, how nicely it highlights. You can also appreciate these little prickly, little spiking pieces here, which once again are living above the surface of the retina in the vitreoretinal interface. This is a patient that had proliferative disease, so a 67-year-old Hispanic male, 14 years diabetic. The vision of my left eye is weird, times 2 months. He's missed his last 3 annual exams, and you can see very obvious neovascularization of the disc. I would say that some cases don't need OCT angiography as much as other cases. This is one where it was very obvious that he had neovascularization of the disc. But this is just another example of that color overlay feature. You can brilliantly image or brilliantly visualize the green vasculature here, indicating that we are up in that vitreoretinal space. And you can also visualize on the flow overlay image this piece extending anteriorly into the vitreoretinal space. The red within that little kind of strand is an indication that there's actually an active blood source in there, and that would be consistent with there being a neovascular response. This shows you here that if you weren't sure that this was actually neovascularization, you can position your line, which I showed you on a few slides before, but you can position your line at the vitreoretinal interface, and that will show you whether or not this whether there is neovascular response above the level of the retina. If this was intraretinal, this slab would be black. So this is just showing you what you can do by moving those lines. This is another classic case of, does this patient have IRMA? Do they have neovascularization? And you can see here that there are anomalous vessels everywhere here, okay? Just tons and tons of anomalous vessels. So I'm going to show you here how to use the slabs, or customizing the slabs, as I said before. Here's a nice big magnified view of those anomalous vessels. So what you can see on the bottom here is, a B scan. There's some vitreous debris up here, but you say to yourself, what is this? Is this neo? What is it? Is it just vitreous? Very difficult to tell, especially in the presence of all of this anomalous vasculature. So what you would do is you would take your lines that you can see here, and you would move them directly to the vitreoretinal interface. If this was vitreous, this slab would be black. If it was neovascularization, you would actually see an anomalous vessel here. So again, understanding how to manipulate the technology, understand how to move your lines into a custom slab so that you can appreciate and make the most of the technology. So this is what neovascularization would look like. The slab would be completely black if this was just a vitreous strand. This shows you, as I showed you before, the difference in the technologies between fluorescein and OCTA in a proliferative case. Pardon me. So remember that neovascularization is going to leak. So on the FA, you can see all of this leakage, but look how brilliantly you can visualize the anomalous vasculature on OCTA, because these vessels are not going to leak. It's the anomalous vasculature. The blood is still within the blood vessel. Okay, so for the last part of this, I want to talk about something that's exclusive to OptiView called Angioanalytics. Angioanalytics has made a major change in the way that I view OCTA. The reason is that we never understood how patients compared to each other. So we would do a scan and we would say, yeah, we see that the FAZ looks like it may be enlarged, but how do we know, right? How do we really know if that FAZ is enlarged, or is it just large for that patient, right? So this technology, and only OptiView has this. So here's an example, right? You have a patient here that on the left, that's a normal eye. And what this does for you is it measures, you can see the yellow line here, it's an automatic quantification technique of the size of the foveally vascular zone, and the yellow around it is a measurement of the perimeter. Studies are telling us that not only is the size of the FAZ important in predicting progression, but so is the size of the perimeter. So here are the measurements. The FAZ is being measured as 0.172, perimeter as 1.806. So the machine automatically tells you this is what this patient's FAZ is measuring at. Looking at the diabetic eye, you'll see it looks quite different. The diabetic eye has a larger FAZ, larger perimeter area, or larger areas of capillary non-perfusion. And those numbers get even bigger in the more advanced diabetic eye. Now, I will tell you that patients vary in the size of their FAZ. So what might be normal for one patient might not be normal for another patient. So the best thing to do is use the patient as a measure of progression. And I'm going to show you what I mean by that. So here's an example. Here's a patient that we saw in 2015. The FAZ was measured as 0.171. So that we're going to consider the baseline FAZ size. This is a diabetic patient. We bring the patient back a year later for their diabetic eye exam, and we're trying to determine is the patient stable or not. And once again, we use this automated FAZ quantitative assessment, and the machine is now measuring the FAZ as 0.241. Remember that bigger FAZ equals less perfusion, less capillaries. So this patient is worsening. And then we see them back in 2017, and now the FAZ is 0.305. So what's happening to this patient is we have a way of actually quantifying the size of the FAZ and the size of the change in perfusion. Whereas if you didn't have this technology and all you were doing was looking at images, it might be easy to see that this one and this one look different, but what about this one and this one? And what about moving forward? So this actually provides us with data, with numerical data on how the patient's doing. Here's another example. Kind of, again, don't stress on the numbers. I don't really want to emphasize the numbers, but what I want you to appreciate once again is looking at how the measurements differ, how the capillaries differ between scans, and how this machine automatically provides that information for you, depending on, once again, the level of retinopathy. There's also another part of this angioanalytic piece called non-flow area. So this gives you the ability to take your mouse and just click on any area that looks dark, and the machine will automatically calculate how much no flow there is based on where you click. So let's say you were interested in looking at this particular area over time. You just take your mouse, you click it, it's going to turn yellow, and up here it's going to automatically summate the amount of no flow in the designated areas. Once again, this is another way of assessing or tracking progression over time in a pre-designated area. You also can use color. Color will help us with vessel density. So warmer colors, more perfusion. So you can see here that in case of mild NPDR, lots of nice warm colors surrounding the FAZ. As we progress through the stages of diabetes, you can see how the scans are getting cooler and cooler. And you may wonder, well, can I get a percent saturation? Meaning, can somebody measure for me how dense each area is? And the answer is yes. The software will even give you a percent to tell you this area is 14% saturated. This area is 25% saturated. So every part, and that's what these squares are showing. Every part or every piece of the technology is quantifiable and trackable. And here's an example of that exact thing that I just said. Here you can see how every quadrant has a number. So here's a patient that we saw in 2015. The FAZ was measured as a percentage density of 30, this area 46, this area 44, and so on and so forth. And you can see over time how each of these areas is changing on a percent density scale. I mentioned before, just, this is really kind of a topic that needs a lot more research, but looking at the choriocapillaris and assessing it, really assessing it for change. The choriocapillaris is not one of the segmentation pieces that we look at, or the angiograms that we really put a lot of emphasis on in diabetes. But you can see here that these are choriocapillaris slabs, should be nice and dense like this one in a healthy eye. And what you'll appreciate in a diabetic eye is that you can see more and more darkness. These are just color coded, but it would be the same in black and white. When we get to the proliferative angiogram, there's so much black, indicating that this diabetic eye may actually have disease in the choriocapillaris or ischemia in the choriocapillaris as well. Once again, this is something that needs a lot more research. And this is just an example on black and white. Control eye, choriocapillaris, nice, homogeneous, spongy appearance. This is a diabetic patient, and you can see the choriocapillaris lab has these dark areas that we're suspecting are correlating with capillary non-perfusion, and that's just kind of a blown up appearance of this and what it looks on the en-face. So Adam, that is the end of my part. Happy to answer any questions that anyone may have.
Great. All right. Well, thank you, Julie. And let me open up the questions box here. So remember, if anybody has a question, feel free to pop open the box that says questions and type right in there, and we will get to them. So let's see. Clinical question here. So are there similar vasculopathic changes in patients with hypertension or dyslipidemia?
Yes, hypertension may show areas of capillary non-perfusion. We don't necessarily look at the foveally vascular zone as much as we do in diabetes, but you may see overall capillary non-perfusion really in any microvascular disease, because hypertension also affects the inner retina. It's a disease of the neurosensory retina. So same idea, we're looking at small blood vessel disease. So anytime the capillaries are affected, you can essentially get a change in that density or the homogeneity of the vessels. So the answer is yes.
Right. Practice management question here. So right off the bat. So, we had a webinar actually on screening a few weeks ago where you can do OCT on a wide variety of patients. What about with OCTA? What kind of patients do you actually do the scan on? This isn't something that you screen everyone with, right?
Correct. So unfortunately, right now, OCT Angiography doesn't have its separate billing code. So what I would say is that if you're doing OCT and you have this technology, I would probably say you might as well just do OCT Angiography, because remember that you have to get OCT scans to get OCT Angiography. So you're going to get some really nice OCTB scans along with the angiograms. Would I do it on every patient? Absolutely not. I try to do it on my diabetic patients, because that doesn't mean that it always happens. I try to do it on my diabetic patients, especially because it provides so much information preemptively. Definitely do it on my AMD patients, which hopefully will be our next webinar, but that actually picks up a lot of stuff that is very difficult to see clinically as well. So I would say those would be the two subsets of patients that I try to scan the most, is diabetes and AMD. But no, it is not needed on every single patient. But it is fabulous for a practice that has a lot of medical retina, because it's great at picking up stuff. But that's kind of the long-winded answer to your question.
Right. I guess sort of a related question. In terms of actually acquiring the scan, if you're doing a B scan, how much extra time is it typically, and is it difficult if the patient moves? Do you have to start over? What's it like?
Yeah, I mean, it doesn't take very long at all. Each scan takes, it's the same as acquiring maybe a couple seconds longer than acquiring a B scan. So you have to get 2 of them. I would say 30 seconds. I mean, it's really very, very fast. Now, if you have a difficult patient that either moves a lot or has a poor tear film or has lenticular changes, it is challenging. Okay, OCT angiography is definitely going to be challenging on those patients. And something to keep in mind, which I'm glad you brought up here, is that having poor signal strength on the OCT angiography, meaning, a patient again has a poor tear film or cataract, it is going to very negatively impact the OCT angiography. It makes it very difficult to interpret and appreciate what is actually poor scan quality and what's actually poor capillary perfusion. So it's not perfect for everybody. We can do it on, I would say, 80% of patients, it's effective, but there are limitations, and you have to know those limitations when you're doing the technology.
Right. Interesting. Another practice management question. You guys are going in that direction tonight. Do you, and I think you mentioned this in screening too, you use the scans a lot of the time to send out to primary care practitioners, and I guess in this case, endocrinologists as well. The question is, do these other specialists understand what they're looking at if you actually send them reports?
Yeah, I mean, I don't usually send them images. What I will do is tell them that we have, that we have this. I tell them that we have an angiography image, which allows for, visualization of the retinal blood flow, and that it is identifying areas where the retina is not getting enough blood supply. So what I try to do is to really kind of spell out for them, instead of showing them what's going on. I might say that, we don't see anything clinically, because they might be really good at, picking up the direct ophthalmoscope and looking in the back and not seeing anything. So I think it's important to tell them that, even though you might not see anything clinically, we're able to visualize these changes at a, microscopic level, which is telling us that this patient actually has, stuff going on. So pictures, not so much, and it's a great question. No, they don't know what they're seeing. So that's usually, at least in my opinion, not the most helpful. I will tell you that when I send images to the retina specialist, they do know how to interpret these, and that is oftentimes very helpful, especially if they haven't done a fluorescein, or if fluorescein is contraindicated in a patient, then these scans are very helpful.
Right. Question here, again, this has to do with acquisition, I think, and how long it takes. You showed a scan earlier. It was like two of them stitched together, right? It was sort of like a wide view.
Montage.
Yeah, the montage. There we go. Got the word right. So with the montage image, did that take extra long to scan? How does that work?
So you have to acquire an optic nerve head scan, and you have to acquire a macula scan. So it's almost the same as doing, if you had a patient coming in for glaucoma, you would do a glaucoma OCT, meaning GCC RNFL, and then you would do, let's say you would do macula if you we're trying to visualize something else. So, I mean, it might take a little bit longer, but we're not talking about a long period of time, and the machine automatically will fuse it for you if you click the montage feature. So understand that once you get good at scan acquisition, which it's not difficult to acquire the scans, it's really not very much longer. I promise you that. The harder part with those angiography is in the interpretation. The acquisition is the easy part. Learning to interpret, which is why we're doing these webinars, is sometimes the harder part, but once again becomes a lot easier as you begin to see the same type of entities over and over.
Right. And question here, additional resources. So someone who's just getting started out, obviously webinars like this, are a good way for people to get introduced to the subject. Mm-hmm. But what other additional resources would you recommend for people who want to look at a whole bunch of scans?
Right. Well, I will tell you that I know Visionics is working on this. We are in the process of uploading, stuff to the website. There's an academy. It's going to be Visionics Academy, where there's going to be lectures. As you mentioned at the beginning, Adam, I published a book on OCT Angiography. It's all cases. I don't like to promote myself in these things, but if it is a wonderful, very introductory book using this technology, and shows all kinds of different diseases in there. And I'm also always available. I can give you my email. I'm always available to help with any questions that may come up. I don't know, Adam, if you share my email, but it's rjulie@nova.edu. Happy, Adam, if you want to share it at the end with anyone that's here. I'm always happy to answer any questions that anyone has. It's my pleasure. I love to see cases. I love to see what you guys are seeing, what you're scanning. So there's not a ton of really easy stuff on OCT Angiography, so it's challenging when you go out there and try to start finding things. So those would be my best recommendations. But once again, any questions you can send my way.
Great. And again, in the discussion thread that's going to run beneath this archive, which is how the majority of people are probably going to see this over the next several years, the discussion thread beneath this video, we can list your email address there as well, or people can ask questions right on ODwire, and you'll be notified. So great. So a question here, this may be beyond your pay grade. It has to do with cost. And how does that actually work? Now, I guess the angiography unit itself is sort of an add-on feature to a lot of OCT units, correct?
So the answer to that is no. It's not just a software update. So at least for OptiView, which is the company that I'm familiar with, the Avanti is the technology that could house the angiography. Not any of the other units can, because you need to have a certain amount of speed in acquisition. So you wouldn't be able to put it on the iView or the iFusion. It has to go on the Avanti. So that's the technology that houses this technology. I don't know any other way to say it, but it has to be on that unit. Does
Right.
that answer the question? Now, as far as price goes, I'm not going to answer that. I don't know.
Right.
I don't want to mislead anybody. That would have to go to the reps.
Right, but it does sound like the devices that can do angiography can also handle all the other functions that a regular OCT can.
That's correct. It's like the Rolls Royce of OCTs. And I will also mention, I know this is a fact, that this company has probably the most affordable OCTA out there. So, and I'm not just saying that because I'm on here. I know that as a fact. It is the most affordable, and the images are, in my opinion, some of the best ones that are available.
Great. All right. Well, it looks like we're running a little bit low on time here. I think we're actually ran a little bit over. But if people want to ask more questions, feel free to come back to ODwire again. This piece will be running on the site, and the discussion thread will be right beneath it. And we'll be standing by to answer all of your questions. So Julie, thanks again for coming here tonight, and thanks everybody for showing up. And I guess I'll see everybody online.
Thank you, Adam. Have a good night.